So let's talk about endometriosis. Boy, let's talk about the pain. Pain is such an overriding feeling and image in that film. We are joined by Dr. Michael Sector, originally from Calgary. Oh, you can clap for him later. Originally from Calgary, Dr. Sector completed medical school at University of Western Ontario, followed by a residency in obstetrics and gynecology at the U of T in Toronto. And he further specialized with a fellowship in minimally invasive gynecology. And we got him back here in 2018 and brought his advanced surgical expertise and new perspective to this treatment of endometriosis in our city. So he is our endometriosis specialist for both medical and advanced surgical treatment and is widely known in Calgary for his skill. So the world of endometriosis is not new to you, and the pain that these women that we just saw are feeling for years and years and years is not new to you. But how the hell are we still at a time where it's taking years for these patients to get diagnosed?
Well, first of all, I'd like to say how honored I am to be here tonight, or this afternoon, rather. You're right, there's a lot of suffering still in Alberta. I think in the last 10 years in Calgary, we've grown a lot. And our department has gone from one endometriosis surgeon in Calgary to now 10 in 10 years, which is great, but it's still actually not enough. And there are still substantial delays to diagnosis, delays to being seen by a qualified surgeon who can help, and then delays after that for ongoing care. And, I think the first piece of that is that your pain is not normal.
Right.
And recognition that your pain...
It's not all in our head?
It is not.
It's not all anxiety and menopause and in our head? Wait, we really have learned today.
No, it's not normal, and you should seek care, and you should seek somebody who has the insight and skill to help you with it.
Well, that might be, and again, God bless family doctors. Mm-hmm. God bless family doctors because they are the backbone of care in Alberta. But oftentimes, they do not have perhaps the resources, or sometimes I think we do not present with pain. So we're having pain. Okay, well, everybody has pain. Take a Tylenol and try some running. Right?
Yep.
And then have some chamomile tea. Give me an Ativan. So what can we do as patients as we are on the road to trying to get a diagnosis because something unusual is going on? The key things to me might be that the pain level seems to be 10 out of 10 frequently. Mm-hmm. What else should we be noting that might give our doctor a more accurate portrayal of what it is we're feeling?
The classic symptoms of endometriosis that we talk about, pain with intercourse, pain with period, pain during sex, pain with bowel movement, those are all important, but I think pelvic pain in general should be enough of a trigger to start thinking about this disease. I don't think you necessarily need to have any or all of those symptoms. I think any pain in general should be enough to start thinking about this and start working down a pathway towards an accurate diagnosis.
If we come to the family doctor and we may get an ultrasound or something that may look mm-hmm. normal, how would we then help us to advocate with the family doctor to move on to the next set of diagnosis, the specialist? Yeah. What could we say? Well, the ultrasound is normal. Well, what could we then do and we're learning about advocacy today. Yeah. How can we then move on to the next saying, no, actually, this is not normal and it needs to be investigated?
I'm really glad you asked that question. The vast majority of the patients that I see with endometriosis have a normal ultrasound. Okay, so...
You're fine. You're fine.
And you know, you know, there are some obvious findings on ultrasound, stage 3 and stage 4, that are pathognomonic, or obvious that this is what this is, and those patients get referred. But a lot of people have fully normal ultrasounds, and you know, one of the things that we have innovated and have changed in the last 5 years is advanced imaging. So, you know, we do have access to what's called an endometriosis protocol ultrasound that can actually map where it is in the pelvis.
What?
Yeah.
That's a thing?
Yeah, it's great, actually. But access to that is also a problem.
Okay, yeah.
Because now that we know that that's a thing, it takes something like 5 or 6 times as long as a normal pelvic ultrasound. It takes qualified technologists, and it takes qualified radiologists to interpret these. So, and the other thing is that even in those circumstances, most people will still have a normal endometriosis ultrasound and still have superficial endometriosis that can be widespread.
Okay. Oh. Okay, so you're setting us up on a journey here. But is your message that the patient should feel empowered to not just accept ultrasound normal, this just happens?
You know, if you're in my office and you have pain and your ultrasound is normal, that's endometriosis until proven otherwise.
Rather than there's no horse showing up on this ultrasound, so I'm not going to look for a zebra. I'm just going to say there's no horse, so you're good to go. That flips when one gets to the specialist. This seems to be where we get the care.
This is where you get the care.
How do you feel about seeing 300 of us over the next couple of minutes? Okay. Surgery seemed to offer relief for some of these women. Options for treatment besides surgery?
So this highlighted a lot of the treatments: progesterone, oral contraception, Lupron or Lissa. None of these drugs are actual treatments for endo, right? And I think that that's something that is a bit misunderstood, is that they can help a lot of the symptoms. They can shut down the menstrual cycle, but they don't treat the disease. And so in a lot of circumstances, the side effects are worse than the treatment, and it actually excludes a whole group of people, and those are the people who are trying to conceive a pregnancy. And so if you are trying to conceive a pregnancy, what medical options do you have to treat your endo? Frankly, you have zero.
Okay, good to know.
Yeah,
All right.
well,
thank you.
And that's a major problem, and that's you know, discussing the role of surgery is complex and nuanced depending on where people are in their life.
Yes.
And so, you know, there aren't a lot of great therapeutic options that are non-surgical.
Okay, so would you like us to raise a whole bunch of money, and then you can, on behalf of all of us, go and lobby for more research so that we could have more treatment options?
I would be delighted to do that. I would love to expand access to endometriosis care. I'd love to see multidisciplinary centers in Alberta. I'd love to see access to advanced fertility treatment.
Yeah.
I'd love to see expanded access to pelvic floor physiotherapy. I'd like to see expanded access to mental health relating to this condition. And we would love to grow and treat people you know, widely and across the province.
Well, you just call out, because your girls are here.
Great.
And we are ready for you. I don't want to take up all of Dr. Spector's time with just my questions. Does anybody have a question? All right. She's coming to you.
Okay.
Tippy tap, tippy tap, 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 tap. Hi.
So just to be clear, endometriosis cannot be cured. The surgery just takes off the growths that are currently existing, but they will regrow over time.
So this is a question that we get a lot. And, you know, with complete excision and expert excision, while it's not a cure, the recurrence rate of those lesions goes down over time. So, you know, if I take somebody to the operating room and they have stage 3 or stage 4 and we excise every drop of disease from the diaphragm through the appendix, those patients still have a risk of recurrence. So even with complete removal of endo, uterus, tubes, and ovaries, some patients still get recurrence after that.
But it not necessarily is, okay, your reprieve is going to be 10 days and then it starts to grow back again and it's going to grow and grow and grow and grow.
You know, people's experience is variable. Some people have...
So it is from here to here.
Yep. Okay. Some people do have recurrence after 3 months, after 6 months, after a year. Some people go 5, 10 years. Some people never have recurrence. It's extremely unpredictable.
So much like what we learned about menopause this morning, is every experience is different.
You bet.
Okay. Other cues?
Based on you saying every experience is different, last year I got told by my specialist, I don't want you to die before you're 40. So, you know, finally having someone, my first specialist was, I don't want to see you. And then finally having a specialist who was advocating for me. Oh, nice. And then, you know, being told that, how do you continue to make a plan from that, you know? Because in my head it was like, okay, since my first period at 11, been sick. Daily pain for the last 15 years. And you know, I got super excited. I'm like, we're gonna do this surgery. And then her being like, you are too young. I don't want you to do this just because of all the risks. How then do you, how do you continue to make a plan of what's next when, you know, you've kind of been through the process? You've seen, you know, my specialist has sent me to another specialist, who sent me to another specialist, and how do you
Well, you regroup. You regroup.
Yeah.
You figure out what you want.
Yes.
Is the problem perhaps that they're concerned about future fertility for you? Is that a big thing for you? Is that a small thing for you? So you start with you, right? And don't forget, this impacts mental health as well. The depression, the anxiety. Okay, I am not a doctor. And I will get to the doctor, but I'm saying woman to woman here. We do not accept, I am no longer interested in assisting and helping you. We don't accept that. So you step back, you regroup, you prioritize. You know what? If this is, the problem is that this is going to impact my fertility, I am willing to not have that fertility, to have the quality of life that I am looking for. And then you start, as we have all talked about, you start advocating once again, all the way through until you get someone, and I'm sure it's taken you a while, and I'm sure it's taken a toll, and again, the mental health, but you keep going until you get somebody who's in your court and is going to talk about, what do you want? What do I want? What is the right thing for you? And that is, and only then, is when you stop. Okay, I'm sorry, go ahead.
Yeah, I frankly, I agree with your advice in that, you know, decision making around treatment plans, it has to be personalized. It has to be what you are hoping for and what you're trying to achieve in terms of your immediate and your future goals. And, you know, sometimes if you're not meeting those goals or if you're not getting what you're looking for, you sometimes have to go for other opinions until you find what you are looking for.
You go, girl. For another cue? Hi.
Hi there. I just wanted to know, what is the plan or policy moving forward with, endometrioma ruptures in emergency rooms? Why are women being sent home without any referral, without any treatment, without any pain medication, and just left on their own to figure it out?
That's a difficult situation. Our emergency doctors right now, they're ass to the wall. They are in very difficult situations, and they are trying to make sure, are you alive? They're making sure you're alive. And if you're alive and you can be dealt with over there, then you're getting. Give us an idea of words we need to say to, again, advocate.
An endometrioma rupture is a hard circumstance, actually. It's terrible. It can cause acute pain. It can cause a pelvic abscess. It can cause blood loss. It can be very problematic. You know, I can't necessarily speak to the exact experience that you've had, but endometrioma, the existence of an endometrioma on an ovary implies that there's advanced stage, like stage 3 or stage 4 endometriosis there. And, an acute rupture is a profoundly painful and inflammatory event. Surgery is not always recommended in that acute time frame. And in fact, me personally, I don't often do it then and there. But what you should hear from healthcare professionals is that you have endometriosis. It looks like it's advanced stage endometriosis. You need to be seen by a specialist who can manage this for you.
And maybe for those with endometriosis, maybe you need to stack up your notebook and your research now. Maybe you need to know what the options are out there. Maybe you need to know what to expect. So if you are in a situation, you can say, actually, I have endometriosis. These are my symptoms. This is my quality of life. This is what I live with, so that you are prepared if somebody needs that information, in an emergent situation, like in an emergency room. We got a couple more. Go ahead.
Hi, I have a question. My daughter's been misdiagnosed for 10 years. And as a mama, I kept fighting for her. And we finally did see a specialist who diagnosed her with stage 4 and then told her option was medication. We were not happy with that as her parents, and we have consulted in the States, in Tijuana and Greece, and know that she's a surgical candidate. We are currently on your wait list, but we are wondering, do we have to, when we see you, is that going to be a fight to get you to approve that? It seems with other, doctors that medication is the way that they want to go to, and if we opt to go a private route outside of Canada because it's a year to see you, 2 years for surgery, what does my daughter's care look like when she gets back to Canada?
Tough. You've put him in a tough position, I think. No shit, Sherlock. Just because he's not seen what you're asking him to comment on. But maybe can you comment on the trend towards medication, about surgery, the difference in treatment there?
Thanks for your question. I'm sorry about our waits, and I'm sorry about the suffering that your daughter's going through and that your family's going through. You're right, care is nuanced, but generally speaking, regardless of age, there are some medical comorbidities, but we're pretty open-minded when it comes to surgical care, even in adolescence. The trouble with surgery is that results are hard to guarantee, especially in younger people. We do see higher rates of recurrence over somebody's lifetime. But generally speaking, advanced stage endometriosis deserves attention and may deserve a look and may deserve an operation here in Canada also, here in Calgary. So I would be optimistic. I can't get into too many details, obviously, without really looking at everything, and I don't have anything in front of me, but I could reassure you that I think your family will receive excellent care here.
Could you please also just comment on coming back from a surgery? What we do to ensure that we can get some care if care is needed?
Yep, I have a lot of patients here who, rightly so, could not afford to wait. And, if you're 39 years old and you have bilateral endometriomas and you need to go for IVF and hydrosalpinx and you need surgery before, you should get surgery as fast as you can. It's not a good system in Canada right now. We don't have enough access to surgical care. And people do go abroad, and I have people who come back from Romania and people who come back from Kensenervo, and ultimately the answer to that question is we need to expand access to surgical care in Canada. But even for people who do get treatment abroad, we usually accept those patients into care and we continue to follow them. And some of them need to have repeat operations here in Canada, and some of them need to have hysterectomies when they're done. And we care for those people the same way that we would otherwise.
Judgment calls every step along the way, hey? I don't envy the folks that are knee deep in that. Another question.
Since you've been here since 2018, I believe you said, With the provincial government change and the cuts to healthcare, have you noticed the average for diagnosis times going up, the average times for accessing care going up at all?
The timing of that, my arrival in Calgary, coincided with fairly good expansion of our surgical services in terms of minimally invasive surgery. So I would say that I have seen care expand, and I don't think that we, in general, are seeing more delays. I think we're actually getting better at it. But we are also fighting with our provincial government to, get access to operating time to be fairly compensated for the very challenging work that this surgery is with stage 4 endometriosis. We've been fighting with them to get access to diagnostics that are more accurate. And, I think that as we see more and more people, we need more and more services. But I think that the awareness in our community of obstetrics and gynecology and family medicine has been pretty good. And I think that access to care and timely diagnosis has actually gotten better in the last 10 years.
And add to that, all the people who are moving here every year, right? So if you bring 200,000 people last year? Like, you bring 200,000 more people, and we've not expanded the services and the department. That automatically is going to mean, extra weight. Did you have a follow-up?
Well, just at my GP's offices, because they cut down the visiting time to 15 minutes for diagnosis.
Yep.
There were a lot of signs up saying, like, please, patients, do your own research ahead of time because the doctors don't have time to do it for you. And it's just, I'm wondering.
Not
if
at
that's-
Facebook U.
No. Yes, apparently not at Facebook U.
Yeah.
But yes, just they're encouraging people to go and get their Google medical degree, I guess. And I was wondering if, given the 15-minute visiting time for GPs, if that's trickling down to people taking longer and longer to get referrals to specialists like you or getting diagnoses?
Certainly it can impact patients, and the state of healthcare and a public healthcare system is troubling sometimes. And, I sometimes think that we may get referrals quicker, actually, in that sometimes if you can't access or really investigate it, or if you have a suspicion, sometimes people will refer earlier, but it doesn't sound like that's been your personal experience. But, there are many challenges in our healthcare system, and I think it's okay to acknowledge them.
And I think that we all have an obligation, I think, to arrive at somewhere with questions, with information, and being very clear. The time, everybody's time is at such a premium that if we tell the story, well, I was a 9, and, be very succinct and be very clear, and be clear about what it is you're looking for. I'm looking for further help in this area. I'm looking for, can you deal with this? If you cannot, can you pass me on to somebody else? Just as a basic, medical care, I think is probably a good idea, because you're right. Our 15 minutes, and it's really 12, by the time they get in and log into their computer. So I think it behooves all of us to.
Yeah. Yeah.
Well, yeah. And then for you to drop your drawers if you have to, do that. So I think it behooves all of us to be prepared. I see one right up here.
Okay, I kind of have a two-part question, but I've been down the endo road. I had surgery March 2023. First part is currently what is the wait list to get into gynaes in Calgary? And then once you see the gynae, what is the surgical wait list now?
What's your triage situation?
Hard question to answer. In general, the wait list is, as I said, if you're not necessarily seeing gynecology, you might be seeing an endometriosis specialist. The wait list for a new referral typically is around a year. We do have a few new hires who are joining our practice, and their wait list will be at a year, probably within 3 months of practice.
Wow.
Because everybody knows who's coming in, and that we need to sort of mobilize more patients into more resources. Typically, the wait time for a surgery is also about a year. And the reason behind that is that these surgeries take, in general, 2.5 to 3 hours. So you can do about 2, sometimes 3 in a day. Most surgeons in Calgary can't expect more than 1 OR day a week.
Right.
So it doesn't take very long. Like a day of clinic is a month of surgical patients.
Right, right. So expanding OR. But then we don't want you going in, when you're tired from doing 17 surgeries that week. So like, don't overextend yourself. That is precision medicine you are practicing.
It is, but I think a lot of us would have the capacity to do more if it was available to us.
Well, if you follow the Mediterranean diet, apparently, is what we've learned today. That's gonna help your chances. We learned all about that. Another question over here?
No, just finishing up here.
Oh.
After I had surgery, my gynae was like, I was like, okay, well, like, what do we do now? And he was like, you just see how you do, and if you need meds, then great. And I was like, okay, and like, do I just come back in and see you? And he's like, well, no, you'll be off of my list because other people need to get in. So, if you have issues again, just get re-referred. And I was like, so then I have to wait like 1.5 years, year to get back in? Like,
Yes.
Is that still kind of what you do, or?
Probably worse.
Well, everybody's practice is a little bit different, but you touched actually on 2 things there. And the first is that, surgery for some people is...
I know.
Is this the end?
No, just.
Oh, you can still hear
There
me.
we go.
Surgery for some people is the end of the line and that they feel better for the rest of their lives. For some people, surgery is the first step in a longer journey with recurrence, with pelvic floor dysfunction, with abdominal wall dysfunction, with, it is oftentimes just the beginning of the journey to, getting your health back. A lot of the endometriosis surgeons recognize that, and for the most part, if we've operated on somebody, we see them back quite quickly. We sometimes welcome them back, years later. The reality is that trying to get people back in, the more people that I try and see quickly who don't have a diagnosis, who are looking for a diagnosis and treatment, means that there's less access for the people that I have already seen and already operated on. And that's one of the challenges in my practice right now, is that I just cannot make enough time.
When you said, and sometimes we welcome them back, immediately my mind went to, and sometimes we don't. And sometimes we block the door because we don't care for them, so we don't welcome them back. And I'm sorry, that's just after a long day and not enough Mediterranean diet food. Another question? Yeah, we're ready for you. Is there a microphone near you?
Oh, I just had one last question. Sorry, and then I swear I will give the mic
That's
to
okay.
somebody else.
We're going to bring the hook out. What is going on up there?
Just wondering if you work with any like other specialists when you do endosurgery. Like, do you have a bowel specialist with you, or are they on call?
It's a great question. So, for a long time, we did not have colorectal surgeons who wanted to do this kind of work. It's complicated, it's nuanced, and I do now have I have partnership with a few surgeons around the city, but we have one now at Foothills that I work with very frequently, more than once a month, who assists me with bowel resections as needed, who will, help me with complex cases that are more than what my surgical skill set can handle, mostly with a low anterior resection. So, there are circumstances where they're on call for me and circumstances where they're booked to join me for a 5-hour surgery. The key is to actually avoid the situation where you need to call them in. And that reflects back to the diagnostic imaging that you do before, the colonoscopy that you do before, and make sure that you have them in the OR ready to go and not as ad hoc.
You always want to know what you're going into, right?
You do.
Have as clear a picture as possible.
Totally. And we do the same thing with the urologists, and we do the same thing with the thoracic surgeons.
Wow. Okay. Over here?
I have
No more questions?
I have a question.
Oh, where are you?
So I'm up here. Sorry.
Okay, thanks.
So I, after a long wait, got into a gynecologist who told me that my pain was normal and it's probably IBS, which I'm sure lots of people have had that. So I found through the U of C, they've been doing a study, I the impact of oxytocin through nasal spray on pelvic pain, and they don't discriminate on pelvic pain. So when they needed my doctor's signature, and I said my gynecologist said it was IBS. They said it really doesn't matter. It is proven to lessen pain if you have between 4 and 8 pain level on the scale. I'm just wondering if you have heard of anything like that, or any kind of research backing that. I know in the
Or
States
is there a
it's
website
different.
or something that maybe we could all go check?
You know, I am familiar.
Michael's fancy endo website?
I wish I had one. I am aware of the study, and you know what? As endosurgeons and as pain specialists, we are always looking for things that will help treat people's pain and improve their quality of life. You know, I haven't seen big studies on inhaled oxytocin or intranasal oxytocin yet, specifically for endo, but I would certainly hope that more research is coming.
I think there is a website, a research website at the U of C, isn't there? And it gives you all of the interesting things that are going on. That's right. Just go to UC, start nosing around, and then get into researches and trials. And I'm sure there is a website just for that. We have time for one more. We wish we could keep Dr. Michael here and answer questions all night long. But if we could just go through one more, and then we will wrap things up.
Hello, I'm here.
Hi.
Forget my ignorance, but do we have some sort of endometriosis treatment center in Alberta? That was question 1. Question 2, does endometriosis end when we enter into menopause? And if so, is surgery required at that point?
I think those are both great questions, and I'm going to answer them separately. There's no unified endometriosis center in Alberta. There are.
Remember, we're going to build you one.
This is the dream.
We're fundraising.
You know, we have close relationships with trusted surgeons, and we collaborate as a group of 10. We operate with each other several days a month. We have pelvic floor physiotherapists that we work with. We have radiologists. We have assembled a team around us, but we haven't built a brick and mortar center for endometriosis yet. Is it something that I think would be a great asset for this city? It sure would be, and I think that it could be something that we'll experience in the future, but that doesn't exist quite yet. The second question is about postmenopausal endometriosis, and there was common teaching that if you end cycles, you end endo, and so people would have hysterectomy and removal of tubes and ovaries and enter menopause early in life, and it turns out that that doesn't actually fix the problem, and that this ectopic endometrioid-like tissue can continue to grow and generate its own estrogen in some circumstances. So it's not common for people to have a lot of symptoms after menopause, but certainly some people do. Some people have implants that will continue to grow and experience pelvic pain, bowel obstruction, kidney obstruction, even post-menopausally. And so, you know, while it's less likely, it's still a real consideration. Surgery is still an option in some circumstances, but not in all. And it's kind of individual decision-making around the cases.
Has anybody else noticed that menopause is a real bitch? Like, all day long, we've been learning all the various things. Okay, stay tuned, sit tight. I was going to say stay tight, but that's... I stopped myself from doing that. I really do need a snack. So that's it. Like, that's it. What a day we have had. So many notes, so much great information. This is going out on a couple of websites. O'Brien Institute and of the U of C, what is it? What's the... Calgary Health Foundation and the O'Brien Institute for Public Health. Our sessions today will go out on those various channels. So if you miss something, or you just want to go back again, or you want to say to somebody who maybe didn't hop on the free boat like we did early, say you really should have listened to this because it was fantastic. When do we get access to the specialists that we have had access to today? It's been phenomenal. So Erin, thank you to you and your team for making it all happen. These speakers have just been great. How did it feel to walk into a room full of women? We view you as an ally. So we are happy that you're here.
I identify as an ally.
Well, we do have menopausal rage. And when the Dr. Drew thing, when he was on the radio saying, oh yeah, that's just a little nothing. Okay, Dr. Drew, you come here and say that. You come here and say that, but we're very happy that you're here. What a great way to wrap up our day of learning. And I think that you've left a lot of people with, maybe they're looking for a place on the wait list, or they're on the wait list. I think you've left them with an image of hope, because when they get to you, we feel like you will listen to us as patients. And as we've also learned and discussed today, that's not always the case. And sometimes we have to just be a little bit louder because people aren't listening to us. We feel like you would listen to us. So we like you.
Appreciate that.
And we feel like you have given us some hope for the endometriosis community, because my own endometriosis is gone. Erin, did you want to say anything, or should you just say goodbye? Say thanks. Thanks for coming. Let's continue this conversation, hey? Let's continue advocating for ourselves. Let's continue uplifting our community and our sisterhood on this International Women's Day. And let's continue moving the conversation forward about we're not just small men. We're women, and everything about us is different, and we've got some issues that we would like addressed. So thanks for coming. Safe drive home. See you on the other side.
Thank you.